Hello, everyone. Welcome to today's Research America Alliance member web meeting. It's a lot to say in one sentence. Thanks for joining us as always. And as always, thank you for your partnership. We so appreciate our Alliance members. You are what we do. And so thank you. I am so pleased to have with us today Dr. Walter Koroshetz. I'm sure you all know him. The director of the National Institute of Neurological Disorders and Stroke, or NINDS, at the National Institutes of Health. Dr. Koroshetz will be speaking with us about combating and really understanding long COVID. And I know that there's a soon to be launched research program that we'd love to hear about in that regard. Please type your questions into the Q&A box as we go along. And my colleague, Terry Schwartzbeck, will pose as many as we can in about a 30-minute period. I think that's about as long as we can ask Dr. Koroshetz to stay with us. So with that, Dr. Koroshetz, let me turn this over to you.
Well, thank you, Ellie. Thank you for Research America for hosting me. And as mentioned, I'd like to talk to you a little bit about what we know and probably more about what we don't know about what we call the post-acute sequelae of COVID. And so I'm sure that people have read in the paper about people who have persistent symptoms, difficulties, weeks, now months after they had an acute infection with COVID-19. And that's clearly what drove our attention most prominently because there have been 31.4 million people in the US infected with the virus. So even if a small percentage have persistent problems, it turns out to be quite a few people.
Yeah.
So we really need to try and understand what the problem is and what we can do to attenuate the suffering that seems to be long lasting after COVID. I would also say that the other thing which is important is to understand what COVID's long-term effects have for health in general. So that's another post-acute sequelae of COVID. We don't really know if there are, say, long-term effects on whether you or a person would develop atherosclerosis or dementia at a higher rate because they had COVID, but because it's affected so many millions of people, it's really important to start those studies to see if there are going to be kind of long-term consequences in terms of the risk of developing a common disorder or maybe a rare disorder even. So those are also bundled into what we call post-acute sequelae of COVID. And then the third component is the fact that we know that COVID affects so many different body systems and causes injury to so many body systems. So one can develop a myocarditis. The virus can affect the cells overlying the blood vessels, so-called endothelial cells. It affects the kidney, the liver. We'll talk a little bit about effects on the brain. So it's really important to know how the body repairs itself after COVID, after suffering these kind of injuries. So the program we're going to be talking about has those three components. One is to look at people who have symptoms, so-called long COVID symptoms, people who have suffered injury due to COVID, to know how that repair occurs and how well the body repairs itself. And then thirdly, hopefully, it's not going to be a big problem, but we have to keep our eye open. Are there long-term effects, 5-10 years down the road because of this pandemic? And the goal is always in all three of these aspects to try and understand it better and to try and do whatever we can to prevent or treat persons who are suffering. So that's kind of the umbrella of what we're thinking about here at NIH. And as you know, there's been a tremendous amount of research here that's gone on to develop the vaccines, study the vaccines, to develop treatments for people who have COVID or are hospitalized. We've done work on drugs that affect the immune system that may tamper down the immune response to COVID when it gets out of control. Research to look at how to prevent clots that cause stroke or heart attack or pulmonary embolism in people with COVID. But the new program is really focused on these post-acute sequelae, as I mentioned. Now, if we think about the condition itself, it's a viral infection. It's primarily a respiratory infection, but then it can affect many different organ systems. And then we think that most people, you can detect virus when you're infected, but then you can't detect it afterwards. Weeks, sometimes a couple of months afterwards, you find that it's no longer detectable in the person's nasal mucosa or even in secretions from the lung. So you would think that the virus infection is over, and that people should start getting better, but a lot of people are not getting better, or at least not getting better as quickly as you would expect. So now in people who are hospitalized with COVID and are sick, particularly those in the intensive care unit, the expectation is that the recovery period is going to be long. The surprise with COVID-19 is that many people who are never needed to be hospitalized are still having persistent symptoms. And so I'd say we have to think about those two groups: people who had infection that they could manage at home. They may have had fever, shortness of breath, sweats, always have fatigue with these kind of infections. And then what we found out early on, mostly from data coming out of Europe, was that in hospitalized patients, about 50% of the people were having trouble even 2 to 3 months after the onset of their infection. And then in the summer, the CDC, our CDC, did a study of people who never went into the hospital. And there the surprise was, yes, that about 19% of those people were still having trouble at about 3 weeks after one would have thought that an infection is cleared. And if they compared that to what would be expected if it was the flu, and then in that instance, you would expect, 90, I'm sorry, I should have said 35% of people are still having trouble. If it was flu, it would have been 10% of the people who would still be having trouble. So that was the first indication that a large percentage, up to 35% of people who were never hospitalized, are still having trouble weeks after their infection. And since then, we've learned more and more that this is not so uncommon. And the symptoms are usually a cluster of symptoms. So if you look at what's been reported, there's a list of maybe 30, 40 different symptoms, and people on average have 13 or 14 of those. And they seem to form in clusters. We don't really understand exactly the nature of the different clusters, whether it's related to the infection or whether it's related to the individual. The most common and probably the most debilitating symptom is usually fatigue. So something we know about, we all have it. We get an infection, we all feel kind of under the weather, we can't exercise to a full extent, we're tired, hard to concentrate. And that is common with infection, but it's persistent in almost all the people, up to 90% of people who have these persistent symptoms out, weeks to months after their infection. And along with fatigue comes trouble with concentration and trouble with attention, trouble with memory. Maybe not so much different than what we experience when we have an infection and we have a lot of fatigue and fever and just very hard to concentrate, pay attention to things. It goes under the name I've seen in the lay literature as brain fog. And those go together. And then there's sleep disorders. A large percentage of people have trouble sleeping, falling asleep. There's a lot of different pain syndromes that people have explained to their docs. Pain in the joints, pain in the muscle, particularly pain in the chest, and persistent shortness of breath. So as I said, it's a respiratory infection. Frequently, there's shortness of breath with a respiratory infection. The difference here from what we've heard from talking to doctors taking care of folks like this is that patients are complaining of shortness of breath and their lung function appears to be normal. So the cause of that sensation is not entirely clear. Headache is also really important in these patients. Oftentimes, high percentage of people with persistent headache, particularly if they had a history of migraine in the past. And then there's autonomic trouble, particularly GI tract trouble, diarrhea, and also what's called postural orthostatic tachycardia syndrome, which is a racing heartbeat when you stand up. Sometimes it comes and goes seemingly out of the blue, big changes in heart rate with this uncomfortable sense in the chest. The virus infects the nose, and it actually destroys some of the supporting cells in the nose. So loss of smell and taste is very common with the infection, and that's going to persist. If there's injury to those cells have to regenerate before you get your sense of smell back. And then, of course, exercise intolerance is big. If you're fatigued, that comes with it. People get tired very quickly with even minimal exercise. There's something we're a little bit interested in, we're still exploring, and that's what's called post-exertional malaise. And that's, people have good days and bad days with this syndrome. And some people on a good day, they'll go out and exercise, and then they'll pay for it the next couple of days, feeling wiped out by even, going shopping the day before. So kind of a delayed but long-lasting severe fatigue, sometimes with feeling really sick too with that. And then we can't underestimate the fact that, this pandemic has been an incredible stress on everyone. If you've suffered with COVID, there's an added stress that you're sick. And then if you're not getting better, then the stress is magnified by the fact that, boy, I thought I would get better and I'm not getting better. So I think there's there's a lot of difficulty in managing stress, which leads to a lot of anxiety, post-traumatic stress disorder, and actual depression is something that has to be paid attention to in this condition. Now, what we know about the cause is really close to zero right now. We have certain infections we know, like mononucleosis, may take 6 months to feel better after mono. What we hear is that people are still getting better, but it does seem to be a significant number of people who may be really slowing down in their recovery at 6 or 7 months. There is another condition called myalgic encephalomyelitis and chronic fatigue syndrome, sometimes called MECFS. And that's been around for many decades. Very difficult to understand what's the cause, but many of those people who have this chronic syndrome, very similar to what I just described, had it started by some incident, like a viral illness, but because it was never really investigated until years later, it was never clear what the virus was or why they responded the way they did. So, I guess one big concern is that a number of people after COVID will progress into this kind of more of a chronic problem. So that's why we have to really work hard now, and because we're going to make a difference for people, then this is the time to do it. So the program that NIH is about to launch has these it works on these 3 multiple components I talked to when I first started. And what we're doing, first of all, is really organizing across the country, establishing research cohorts of people who have these symptoms and studying them intensely. But also at this opportunity in time, because COVID is still present among us, we can actually also study how people recover from COVID. So most people will recover fairly well, but we can now compare people who recover well versus those who don't recover so well, or people who recover quickly versus those who recover slowly. It gives us an opportunity to compare what's different about those two groups of people. It may be something about the individual, their genetics, could be something about the infection. We don't know actually whether the virus is gone from the entire body. Could it be hiding somewhere, still causing a response inside the body? We don't know that yet. We have to really study that. Could it be an autoimmune reaction? Certainly with COVID, there's big generation of immune response, antibody response. We know that in certain instances, you can get an antibody response that then responds against the virus, but then overlaps and starts to respond to your normal tissues, so-called autoimmune disorders, which are very common. And they all, every single one of them, has fatigue as part of it. So whether it's rheumatoid arthritis or systemic lupus, multiple sclerosis, fatigue is a big part of all those autoimmune conditions. And then also it's possible, that the immune system has changed in people due to COVID. And the things that we know cause fatigue are oftentimes these inflammatory mediators. They're inflammatory molecules that are released from white cells, the cells that respond to bacteria and viruses. But those substances are known to cause fatigue and some of these symptoms. So we're hoping to, try and move quickly and get this research going. Because as I said, I think the chance of helping people is greatest in this, short time period. It's going to become more difficult, not impossible, but we have to be persistent to get answers. But I think there's the unique opportunities now to get answers quickly to help people who are, still coming out of into this recovery period. So that's kind of where we are, and happy to answer any questions, Ellie.
Oh, wow. It's daunting to think about. One of my questions relates to coronaviruses generally. So with HIV/AIDS, I guess that your immune system is compromised, and then you have a constellation of symptoms having to do with that. This is a very different virus. And before COVID, was there already a recognition that new viruses could be dramatically different? A new virus could be so surprising. Is that something that's just always has been known for a long time about coronaviruses or viruses generally?
Well, so that's a really good question, because remember, before this current pandemic, there was Middle East respiratory syndrome and
Right.
then SARS, and those were coronaviruses. And they was very similar. They would hit the respiratory system, and those people became very sick. They developed adult respiratory distress syndrome, high mortality rates, higher than I think than with COVID-19. And so studies of those patients show, yes, very long recovery periods. The symptoms that I mentioned in COVID-19 are very similar. The difference is that with those two viruses, it seems like you got really sick or you didn't get infected. So the difference about COVID is that people are getting infected and are actually asymptomatic, and people are infected and they're staying at home. That didn't really happen with those two. Though, if you got infected with those two, you were in the hospital. So that's
Wow.
the big difference.
These
So
grades, the gradations.
yeah, I think
Wow.
one of the major, I think Dr. Fauci, when I was on a panel with him, said that he's never seen a virus act like this, where you have such a wide spectrum, and some people doesn't do anything at all, and in some people it's fatal.
And I have a million, but I just ask one more and then I'm going to turn to
Sure.
Terry. In terms of the statistics that are being gathered globally, are you seeing symptoms that are just in a few countries or just in the US, not in other countries, or is it pretty consistent across the line where there's good, solid, robust data gathering?
On the post-acute acute syndromes. Yes.
Yeah,
So the initial data that came out of Europe looks exactly like what we're seeing here. So I don't know about other countries yet, but
your
the
guess.
suspicion would be it'd be very similar. Yeah.
Right. Wow. Terry, let me turn it to you. Do you have questions for us?
Yes, we sure do. And just a reminder to folks, you can type those questions in the Q&A box and we'll try to get to as many as we can. We have a question here on cases of, and I'm not going to pronounce this right, Guillain-Barré syndrome, with those suffering from sepsis with infectious meningeal infections, developing infectious induced arachnoiditis caused by COVID-19. There's been some reviewed studies of affected persons with COVID-19 who develop these kinds of syndromes, possibly from a septic state. Have you seen anything like that? Any comments?
Right. Well, so what we talked about in the last couple of minutes are what I would call fairly common consequences of COVID. But as the questioner mentions, there are a number of more rare syndromes that have been seen in people who are infected with COVID. And those usually come in the period of the acute infection. And so there are some people who present to the emergency room with delirium, a very severe confusional state, not necessarily with respiratory trouble, but are found to have COVID. And then there are some people who have seizures when they're admitted with COVID. Some people have very severe agitation with COVID. So the brain is clearly affected in COVID. And so the studies that have been done so far, and people have died with COVID, what they show so far is that there's not a lot of virus that can be found inside the brain, which is the good news. The bad news is that the virus, which we know affects these lining cells of the blood vessels, causes in the brains that we've seen what we call breakdown of the blood-brain barrier. So the blood vessel becomes leaky, basically, in certain areas of the brain, and that then allows and causes these inflammatory cells to enter the brain. And there can be injury in the brain due to that. And then there are some conditions that are seen after infections that they seem non-specific, but they're quite bad, like Guillain-Barré, for instance. Now, with Zika virus, Guillain-Barré was very common, not so common with COVID-19. There's been reports of what's called acute necrotizing encephalitis, which is a very severe condition where the brain basically becomes very severely injured. We think it's due to an autoimmune process. There's been transverse myelitis, which is similar, affecting the spinal cord. So there are these conditions that cause severe damage in the nervous system, but luckily they appear to be rare at this point.
Quick follow-up on that. The increased number of hospitalizations would also exacerbate sepsis, wouldn't it? Just as a function of increased hospitalizations, it's such a serious issue, right? Wouldn't probably kind of a double effect in some senses, or are there direct links between sepsis that we know of and coronavirus or COVID?
Yeah, so the link is related to the fact that coming in the hospital and having all the interventions that are needed to keep you alive increase your chance of getting an infection. So the most classic example is the ventilator. So the ventilator has a tube that goes into your lung, and your lung usually doesn't have any foreign body in it, but that tube allows bacteria to get into the lung. So
right. Oh.
I'd say anybody on a ventilator for more than I don't know, remember exactly what the numbers are, but they're pretty high that you will get a bacterial pneumonia if you're on a ventilator for any length of period of time. And then sepsis is when that bacteria gets into the bloodstream. And that's a severe consequence of acute critical illness.
Terry, I have more questions, but I am turning it back over to you. I know all
Yes,
dominant.
no, we definitely have some. So I definitely want to get to some of these. This
Excellent.
one's quick. Dr. Koroshetz, you referred to the program the NIH is getting ready to launch regarding post-COVID syndromes. Do you have the name for that program, or maybe we can round up a link that we can share with the audience?
Sure. So we picked the most boring, accurate name we could imagine. So what we picked was post-acute sequelae of COVID. And so it's not very catchy, but it's accurate because we don't know if it's chronic COVID or whether it's post-COVID and so post-acute,
Post V.
you can believe that it's not acute COVID anymore. And what the condition is, we don't know if it's one condition or 10 conditions.
Yeah.
And so we call it sequelae of COVID. So post-acute sequelae of COVID, that's what we call PASC.
PASC, and that's an NIH-wide initiative, correct?
Yes, that's right.
Okay,
Yes.
great.
And the Congress, so I should mention that the Congress became very interested in this very early on in the summer. We had meetings with many different congressional members, and the Congress appropriated $1.15 billion to study of the post-acute sequelae of COVID. So not only is the program needed, but it actually has substantial funding. So I think we're going to be able to do really amazing research in this space, and hopefully it'll turn into things that can help people.
Beyond the human cost, if you think about the healthcare costs, the on-the-ground office visits, hospitalization costs that could attend to these post-acute sequelae conditions, I think 1 point something billion is maybe a drop in the bucket against the costs that we could save if we figure this out. And by we, I mean you, not me. So, Terry, I'm sorry.
Preventing people from getting back to work.
That's right. That too, lost productivity.
And the people who are getting back to work, they're working, but it's really hard. It's the effort to get through their day is twice as much as it used to be.
That's the burden is. Sorry, Terry, go ahead.
Yeah. So another question. Initial reports seem to indicate that women may be more likely to experience long COVID more than men. Can you elaborate on what we might know about these sex and gender differences and anything that's being studied there?
So yeah, so good point. I don't think the data is all in, and we've talked to many different physicians, and some of them say it's equal, but most of them say that they're seeing maybe 60 to 65% women. So it's not just women, but it does seem to be predominant in female gender, and that is true about autoimmune conditions. So we talked about a potential cause. So
wow.
Autoimmune disorders, like multiple sclerosis are more common in women. Also migraine, headaches are a big part of this. Migraine is much more common in women than men. And the immune system in women, yes, is a lot of difference between men and women. So the kind of culprits we're thinking about, immune system or autoimmunity, one would expect that women might be affected more than men. If it's persistence of virus, you wouldn't expect there to be much difference, but autoimmune disorders or immune abnormalities, those might be more common and might think that be more common in women.
Would you expect similar proportions, or would it be too complex to compare between something like lupus and coronavirus? Would you expect a similar differential between males and females?
That's a good question. I think you'd have to look and see. I mean, it'd be worth looking at that. I wouldn't be surprised if those relationships are, kind of held across multiple different conditions, including this one. Yeah.
Terry? I know you have more.
And yeah, I know we are almost out of time.
Oh dear.
Yeah, so I don't know if you wanted to get in one more, Ellie.
Would that be okay, Dr. Koroshetz?
Yeah, absolutely.
Thank you. Go ahead,
So yeah, one other question, and with the intent of not distracting for the absolute need for vaccinations, but are there any differences or anything that we know between the blood clotting sequelae of COVID-19 versus the ones that we've seen now in this very limited situation with the Johnson & Johnson vaccine?
Okay, so So they look like they're different. Okay, so in COVID infection, the virus interacts with the lining cells of the blood vessel, endothelial cells, and that lining is necessary to prevent blood clotting. Because you put blood in a tube, a glass tube, it clots, but the blood doesn't clot because of these cell lining. So we think that the injury there is what causes the clotting, and in actual fact, the platelet count, which are the cells that form little clots and clump together, start the clot going. Those cells are not abnormal or they're not abnormally decreased when you have the acute COVID infection and have clotting. So that looks like a pure clotting disorder. Now with the vaccine, it looks different. With the vaccine, it looks like the vaccine is somehow interacting with antibodies to these platelet cells themselves. And that's what's setting up the clotting. And the clotting is so severe that it consumes all these little platelet cells. So the platelet count drops very dramatically. So that's what you see in the vaccine, that drop of platelets with the clotting. That's not what you see in actual COVID infection. You see clotting with a normal platelet count usually. But in both cases, you can see it occur in the veins, which is a little peculiar. Usually the clots that cause things like stroke are in the arteries. But here in both those cases, the veins, particularly the veins that drain the brain, seem to be preferentially affected by the vaccine reaction. But again, as I say, with the Johnson & Johnson, it's less than 1 in a million, so it's quite rare.
Right.
AstraZeneca, I don't know what the numbers are, but again, it's quite rare. But then again, women seem to be, again, there's a predilection for women being affected, at least from the data we have right now from the Johnson & Johnson.
But even if you narrow it down to women, the percentage is still very small relative to the percentage of effects from COVID, of becoming infected and then having effects.
And there are protocols for treating these clots. So.
Oh, there are. Oh, that's great. I didn't realize that actually. That's very good to know. Well, you've been so generous with your time, Dr. Koroshetz, and it was really so informative. I know I have a lot to think about. I'm sure everyone in the audience does too. So we so appreciate your time and what you do for all of us.
It's a pleasure, and I wish we had, so as you said, we have a lot of questions and not a lot of answers yet, but hopefully we can turn that around.
You'll turn it around. I know it.
All right. Thanks very much, Ellie.
Thanks very much. I'm just going to do a little housekeeping here. So thankfully, there is up on the screen, because my memory is so terrible. I want you all to know about 2 more Alliance member meetings coming up. One of them is on our screen now. It is about biobonds, which is another proposal that is Congressman Bobby Rush has developed with the help of Foundation Fighting Blindness that would establish a bond fund to try to address the valley of death in R&D financing, which I know you all are familiar with. It's that point between sure commercialization and kind of really high reward research that might be more risky than what would attract commercial dollars. So similar to the concerns that are driving ARPA-H, the interest in the ARPA-H proposal, another very innovative proposal. So I hope you'll join us on Tuesday of next week to discuss that and have a healthy discussion about it, like we are with these terrific proposals, to get to understand them better. And then I know that down the road, we have Carolyn Clancy, who heads R&D for the VA, and Dr. Ned Sharpless with NCI. So keep an eye on our weekly letter, and thank you again for your partnership and membership. Take care.